Today I'm going to talk to you about monitoring and evaluation, M&E. Now I love M&E, I love a bit of data, but I'm often lonely in this perspective. It's always the last chapter in the action plan and the last section in the grant application. Now this is not because people are lazy or shy of data, it's just that monitoring doesn't sound that exciting, not urgent. We have dogs to sterilise, to rehome, to vaccinate, shelters to run, complaints to respond to, enforcement processes to follow through. These jobs push to the front, collecting data gets pushed to the back. What I hope to do today is show you how monitoring can lead to exciting results and how to minimise the time we spend on monitoring by focusing on those indicators that are really meaningful, so that we can rightly spend the majority of our time on the more exciting and urgent direct interventions with animals and people. I'll start today with reasons why we need to invest some time, the minority for sure, but at least some time in monitoring so that we can evaluate. I'll cover some terminology very briefly, and then we'll dive into case studies where monitoring has resulted in data that shows meaningful and important change that has happened following a DPM intervention. And I'll finish by describing what we need for running future cost-benefit analysis. So, why should we bother? Firstly, your donors, whether private individuals or public entities, will want to know that their money is making an impact. And you may well have to do this to fulfill a reporting requirement. Secondly, you can inform the public of any impacts on them or their dogs, as they are the target beneficiaries of the intervention. Thirdly, you may want to use the evidence formed from impact assessment to lobby for sustaining, expanding, or replicating an intervention. Sometimes it's because there are budget cuts and you suddenly need to justify your DPM expenditure. For those with an interest in a number of locations, for example, national governments or international organisations, they may want to compare interventions in different locations and their relative effectiveness. But perhaps most importantly, monitoring and evaluation allows the intervention managers and leaders to understand and assess their own interventions and in turn learn from this and improve their impact. Because we work really hard, and we want to know that it's working. And if it's not, we want to know that now, so that we can change something. So I've been throwing out a few terms, so I better define them. Monitoring is the systematic and routine collection of data relating to intervention progress, such as how many dogs have been sterilised, vaccinated, or rehomed this month, but also the data relating to the indicators of impact. So monitoring really is part of the daily work. Evaluation is conducted much less frequently, although it should be done regularly to check progress against milestones or targets. It uses the data collected through monitoring to answer questions about what difference did this intervention actually make, and could we have done it faster or more efficiently. It's also sometimes termed impact assessment. Impact is the change we want to see. It's a description of that better future that we are working for, from the perspective of citizens, health providers, elected officials, and the dogs themselves. Indicators are the core of monitoring. They are the measurable signs of impacts, the things we would see or hear if an impact was indeed being achieved. We may state that we are working to improve dog welfare, that's our impact. But our indicator is the proportion of the dogs that we see in poor body condition or with a visible skin problem. It's a measurable reflection of an impact. In 2015, ICAM published a guide called Are We Making a Difference? This is available on our website in several languages. This is the contents page. It shows 8 impacts. These were the 8 most commonly measured impacts that we found when we reviewed literature on this subject. Most projects will have 2 to 4 of these in mind, almost never all 8. For each of these impacts, the guide provides a list of indicators and also guidance on methods of measuring each indicator. So how could you actually collect data on each of these? For each impact, you want at least one indicator, but more is better. It enables triangulation. If you find more than one source of evidence that supports the same conclusion, this will give you confidence that your conclusion is indeed robust. The impact is indeed being achieved. Now is go through a selection of these and share case studies of indicators that have been measured to show progress in these impacts. I want to share a couple of examples of indicators measured through street survey data. The first is from an organisation called Help in Suffering in Jaipur, India, who run a classic ABC intervention, also known as Catch, Neuter, Vaccinate and Return, or CNVR. They focus on sterilisation of female dogs and vaccination of all dogs. Now, this is one of my favourite examples of street survey data. I like it because of its simplicity, but also it shows their long-term dedication to data collection. So they use 6 routes, which they walk every 6 to 12 months on 6 consecutive mornings. You can see Dr. Sanjay in this photo with his clipboard. They are now using ICAM's Talaya app, which I'll come back to again in a moment. And what you see on the graph is simply the total number of dogs seen on all those 6 routes. And you can see their clear decline in that number over time. And although I don't have the data to show you here, they have continued this counting since 1997, so now approaching 30 years. There's no complex analysis here, just the number of dogs counted on each survey event. What makes this so powerful is the dedication to long-term data collection and the consistency. Same routes, same time of day, same survey protocol year after year. This is a similar example from Bangkok in Thailand. Here we have NGO Soy Dog Foundation. Again, this is a CNVR project, but they also do provide sterilisation services for owned animals. They use mobile clinics because their working area is really large, so they can't rely on static facilities. I also wanted to highlight their systematic approach to coverage. Help in Suffering actually does the same. They conduct CNVR of all the free roaming dogs they can access within a district, ensuring they have exceeded 80% coverage before moving on to the next district, then returning to the same area on a 1 to 2 year cycle to top the coverage back up above 80%, each time requiring fewer sterilisations to reach that threshold. Computer modelling suggests that this front loading followed by maintenance is the most effective and cost efficient approach as compared to spreading your sterilisations evenly across time. You can achieve a greater decline in your population for the same number of sterilisations if you can bunch them up at the beginning and then do just a few in subsequent years to keep the coverage high. Because their working area is so large, they use 20 routes, each one surveyed from a motorbike over a period of 1 to 2 hours by 2 people. They completed this survey at baseline in 2016, and then started up an annual survey from 2020 onwards. The data on nearly all these 20 routes has shown a steady decrease in the number of dogs per kilometre of street surveyed over time. And when we look at the average dogs per kilometre, we can see this has shown a very significant decline overall. The street survey also allowed them to measure indicators of free roaming dog breeding activity, specifically the proportion of females that were visibly lactating and the proportion of puppies, and also indicators of welfare, the proportion of dogs that were in visibly poor body condition, either thin or emaciated, and the proportion that had a visible severe skin problem. All these indicators have also declined over time, evidence that their CNVR is both reducing breeding activity and population turnover and improving dog welfare. I'm a big fan of street surveys because they can be really affordable to implement and provide data for several indicators. I think people can sometimes be nervous of street surveys because when they are used to calculate an estimate of the dog population size, there are complexities. You need to be careful about how you set up your sample and thoughtful about your subsequent analysis, so you need a bit of experience. But this simple option is just to establish convenient routes that traverse those areas where you'll be focusing your effort, and ideally a few areas where you won't, which will then function as controls, and then simply repeat a count along those routes, ensuring you keep the protocol the same, starting at the same time of day, using the same means of transport, avoiding days with unusual weather, basically trying to ensure that any change in the number of dogs you count on your route is reflecting a change in the wider free-roaming dog population and not something else. Both these organisations have used ICAM's Talea app for this work. I don't have time to go into the details today, but if you're interested in running street surveys, please check out the Talea webinar on our website. In the second presentation, you can hear me go into detail on how you can set this up. Now, a street survey will tell you whether there is a statistically significant change in dog numbers. But actually, what we want to know is whether this reduction is meaningful for citizens. Soy Dog ran a household questionnaire where they approached a random sample of households and asked them a range of questions about both dog ownership practices and their perception and experience of free-roaming dogs. Lots of interesting findings shared in the publication listed on the slide here. One question was, how does your experience of free-roaming dogs differ today as compared to a memorable landmark event 9 years ago? Of those people living in areas that had benefited from CMVR, most perceived that these problems with dogs to be fewer today, and this is a dose-dependent effect. The more CMVR rounds the neighbourhood had received, the more likely the resident was to say the problems had diminished, while people living in areas that had not yet received CMVR were equally likely to say the problems were greater today as they were to say that there are fewer. This can be quite a powerful indicator for an elected official, but household questionnaires are relatively costly to implement, especially if we consider repeating these over time. One alternative to household questionnaires is to use data on complaints about dogs to municipalities. One challenge is that this data is not always recorded or accessible, or if it is, it may not be to the level of detail that you need. For example, some complaints are about nuisance or dog bites, but others may be a concern for dog welfare or requests for CMVR action. These are clearly measuring importantly different perceptions of free-roaming dogs. So my recommendation is to work with whoever is receiving the complaints to set up a robust system of data capture with clear categories of complaint type and where geographically these complaints are coming from, and do that as soon as possible so that you have a baseline. Another meaningful indicator to citizens and health budgets is dog bites. This is again data from Help in Suffering in Jaipur. The publication is cited on the slide. What we can see in this top graph is a decline in dog bites over time, and that decline occurred despite an increase in the human population being treated by this hospital of nearly 5% per year. So we would have expected an increase in dog bites if there had been no CMVR intervention. This decline will be in part due to there being fewer dogs over time, and in part due to vaccination leading to fewer rabid dogs. But dogs bite for many reasons, and rabies will be the reason in only a relatively small proportion of those. So they also looked at the seasonality of bites and found that the highest bite rates occur shortly after peak whelping season. So the proposed motivation for some of the bites was maternal defensive aggression. These were mothers protecting puppies from a perceived threat, and sterilisation of course directly takes away that motivation and therefore reduces bites. Now let's look at dog bites in Sarajevo, Bosnia. This graph is for the period 2012 through to 2022, and we can see a reduction in dog bites reported by the Emergency Medical Centre in the blue line. These are not rabies motivated, as there are thankfully very few dog rabies cases in Bosnia now, but they are strongly correlated with a reduction in the estimated free-roaming dog population in the city, which you see in the orange line. One point I did want to make, both about this data set and the dog bites in Jaipur, is that this data comes from just one hospital. This doesn't measure all the dog bites in the city, and that's okay. This is a sample from a representative hospital. In the same way that we do not survey every street in our street survey, but use a route that covers a sample of streets, So long as we believe that our sample is a fair representation of our wider project area, it's not biased in any way, sampling is a reasonable approach to making our monitoring affordable. Now I'm going to pause mid-case studies to make a general point about preparing for effective evaluation, because dog bite data is a particularly good example of why you really need to start early. The last two examples of dog bite data may imply that this is easily accessible data. It wasn't. In both Jaipur and Sarajevo, it required significant effort to collect this information, trawling through old reports, negotiating with busy hospital staff to dig out old ledgers. Even though this data was technically publicly available information, data storage was not consistent nor easy to access. Ideally, at the beginning, as a project is being planned, start to talk to who has access to this data. Who collects it? To what level of detail? How is it recorded? Can you help in any way? For example, there are bite case data collection apps from both GARC and WVS. And you can, from the outset, make agreements for data sharing with any of the necessary de-identification to protect personal information. This lesson of starting from the outset to establish data access is relevant for all indicators. Once you have established which indicators are most meaningful to you, make sure that the first step across them all is to measure the baseline. That includes both those indicators that you will measure yourself and those that rely on accessing the data collected by others. You want to find out at the beginning that nobody writes down complaint data in an accessible file, not 5 years later when you're attempting to evaluate whether your intervention was successful. Back to the case studies. And for this next indicator, we are moving to the US, where shelter metrics are the most appropriate indicators for measuring how well the dog population is being managed. Now, this is really long-term data. The top graph covers 45 years, over which time the estimated number of dogs and cats killed in shelters has fallen dramatically. The bottom graph, which covers a shorter time period, shows that adoption has also increased. That's the top line. But not enough on its own to explain the reduction in killing. It was the decrease in intake to shelters that really drove this change. The graphs are from a publication by Andrew Rowan and Tamara Cartel in 2018. They explain all the DPM interventions that were used across this extended time period in the US to drive down the need to kill animals in shelters by decreasing intake. Most importantly, they point out an increase in access to affordable sterilisation, combined with differential licensing fees and behaviour change campaigns to encourage spay and neuter of owned dogs. Now, this data suggests that shelter metrics in the US have always been robustly tracked, but the authors pointed out that accessing this data was challenging and the data points were only estimates. But this has changed in recent years. This is an oversimplification of a long story, but there were two significant milestones that have allowed the US to now track shelter metrics with confidence. One was the creation of a steering committee comprised by all the major animal welfare groups in 2012. This is Shelter Animals Count. This is a neutral, independent non-profit created to support the national database of sheltered animals. But before this, in 2004, there was the Asylum Accords, an agreement of terminology that set out the foundation for a standard way of reporting shelter statistics. They defined what was meant by an animal that was healthy, treatable, or unhealthy and untreatable, both for behavioural and medical reasons. In essence, this distinguished between euthanasia, where the ending of a life was for welfare reasons, and killing a healthy and treatable animal because there simply wasn't the space. This helped both in consistency of recording what happened to animals in shelters, but also helped with professional communication and collaboration between organisations. Once they had a common language for this difficult subject, they could talk about it more clearly, professionally, and without misunderstanding. So the data metrics have evolved. If you look at shelter animal count reports today, you'll see that they split the outcomes into live outcomes, including adoption and return to owner, and non-live outcomes, including euthanasia and dying in the shelter. They do not ask shelters to define whether the euthanasia was of unhealthy or healthy animals. true euthanasia or culling. Although shelters do record that in their own data to help them track their own progress, when it comes to national reporting and tracking, this is combined into one category of non-live outcomes. There is a success benchmark of 90% live outcomes on the assumption that 10% of intake is on average unhealthy and untreatable, although many shelters aim for 95% live outcomes. Nearly 7,000 organisations, both shelter and community outreach, both government and NGO run, submit their data to this national database so that trends in these important metrics can be followed by community, state and across the whole of the US. The final indicator I want to discuss today brings us back to Sarajevo. We all know that owned dogs are a significant source of free roaming dogs through roaming, loss and abandonment. So we need to monitor this owned dog population and, importantly, the behaviour of owners. Dogs Trust Bosnia invested in a repeated questionnaire survey of owners over several years and showed that during their sterilisation campaign via local vet practices, the percentage of sterilised owned dogs increased significantly from a baseline of just 11% to a peak of 72% in 2019. The funding of owned dog sterilisation by Dogs Trust ended in 2019. 4 years later, although the sterilisation percentage had declined slightly, it was still relatively high, and in particular for those young dogs born since funding had ended, the rate was 47% sterilised, much higher than the 11% baseline, suggesting that the practice of sterilising owned dogs had been sustained in Sarajevo without Dogs Trust funding. I would like to note that although I've shared an example of a really quite fast change in the sterilisation of owned dogs, most owner behaviours are slow to change. So ideally we need to invest in long-term tracking of important owner behaviours. One example of this is the PDSA Paw report, which has been running in the UK for 14 years. They use a professional polling company to track owner behaviour with regards to how well they are meeting the welfare needs of their pets. And this is then used to track how behaviours are responding to relevant national policy and legislation, such as mandatory microchipping and changes to import of dogs from outside UK borders. Although this example is implemented by an NGO, the PDSA, this could easily be a national government initiative. I'd like to finish with sharing my experience of cost-benefit analysis in DPM. A few years ago, I started working with a team of animal health economists. We had the ambition to partner with DPM projects in different locations to support them to complete a retrospective cost-benefit analysis, so looking back. I'll explain what I mean by that and where we hit problems using a hypothetical example. Early in this time period, we see this first baseline period. This is what was happening with dogs initially. Maybe some pounds, maybe also some culling of dogs in the streets or culling of dogs in those pounds up until the end of 2014. And then at the beginning of 2015, we see this new orange period. This was the launch of a new humane DPM system. Widespread sterilisation, a boost to rehoming, perhaps the introduction of identification and registration. But there's also a third period that doesn't really exist. It's what would have happened if no new intervention had started. It's called the counterfactual. It's the hypothetical extension of the baseline scenario, the business as usual that would have continued without this new intervention. All of these periods have costs associated with them: staff, medicines, infrastructure. And all of them will have had impacts on things that cost money and things that have a social cost, including many of the impacts I've already mentioned today. So zoonotic disease in people and animals, dog bites, road traffic accidents, all with a cost to health budgets. But also many things that have a social cost, such as animal suffering, feeling safe moving about the streets. Our job in retrospective cost-benefit analysis was to look back at the costs and benefits of the DPM intervention that had been running for 10 years and compare it to what would have been without this intervention, the costs and benefits of the counterfactual. Now, the problem has been that from where we stand in 2026, we can get good data on the cost of the DPM intervention, and OK data on the benefits over the last 10 years. But doing the same for the counterfactual requires us to be able to look further back at the baseline period before 2015 to find out how much it cost to run then and the status of all those impacts back then as well, and then extrapolate this to this hypothetical 10 years of doing business as it used to be done. And this has proven to be a real problem because the data on that baseline period is very scarce. My purpose in describing how difficult this has been is to make a recommendation. If you are right now standing at the launch of a new policy or a new period of intervention, and you would like one day to be able to assess the costs and benefits of this new intervention, please now take some time to look at what it costs to run the current baseline intervention and the economic and social costs that are associated with dogs now and in the recent past, so that when the time comes, you do have a data set that you can use to build a picture of the counterfactual that you are about to replace with your new intervention. I hope this recommendation will save someone in the future from the slightly frustrating situation of not being able to clearly show how much more benefit you have been able to deliver. So just in summary, which indicators you need to measure will depend on what impacts you and your stakeholders are aiming for. But for many DPM interventions, I have seen monitoring of the indicators in this table provide useful evidence. Those in bold I've shared examples of today. And I hope I've not laboured this point too much, but please don't wait until the evaluation report is due to think about what data is required to show what you have achieved. Take some time at the start to consider what success will look like and what data could help you measure that success and get a reading at baseline. This will put you in an excellent position for later evaluation. Many thanks for your time and attention.